Welcome back, everybody. My name is Jay Unick. I'm a professor in the School of Social Work, and so while we're trying to cram as much information into this time as possible, so even during lunch we're going to cram some information in, although it's relatively brief. We've been talking today about interprofessional approaches to dealing with maternal opioid use disorder. And one of the things that we have to do to collaborate together, as has been reinforced repeatedly during this conference, is talk to one another. And the language we use, the ways in which we choose to talk about our patients, and the problems that they have are very important, and they help frame the issue for us. And I think we've had this conversation through a number of times today, and if at this point you don't realize that stigma is an important part of addressing this problem, you've been sleeping the entire time. I work as part of an organization, in addition to my role at the School of Social Work, BHLI. If you've heard of the van that sits outside the jail that does buprenorphine induction, we're the ones that do that, and along with a number of other things. We have to train a lot of people quickly to get into our sort of cultural approach to dealing with opioid use disorder. And so a few years ago, we created this video. And so I want to just show it to you. It's a 2.5-minute video, and it deals with this issue of language. And while a lot of the language that it recommends is a little clumsy, I think that you should be thinking about the reasons why we want to use certain terms. And I'm not advocating particular words, but I am advocating for a focus on not problematizing individuals, not making individuals the problem, but these other issues the problem, and reducing the, as Dr. DiClemente said earlier, we're dealing with human beings, with people, not with diagnoses, and we have to really focus on that. And so there's a lot of, there's some suggestions that we have in here, but obviously this is an ongoing process of language, but I'm going to stop talking and show the video.
BHLI is working on eliminating stigma and improving treatment and recovery. Stigma against persons with the disease of opiate use disorder is harmful and potentially deadly. There are patients with this disorder who feel ashamed and don't want to go for treatment, such that the overwhelming majority of people with OUD do not access treatment. People who do go to treatment and take medication also face stigma. Many people and professionals mistakenly believe that the medication is a substitute for opiates, another addiction. People are punished for getting treatment, so they stop the medication and they often relapse. Stigma is dangerous. Research shows that language affects how people think and behave. The language we use around OUD patients make them think they are bad people. Even among well-trained clinicians, exposure to terms like abuser creates an implicit bias, resulting in punitive judgments and perpetuating negative attitudes. Perhaps that is why only so few people afflicted with OUD seek treatment. We must change the language in order to change outcomes. Instead of addict or abuser, say person with a substance use disorder. Instead of clean, say addiction-free. Instead of saying a person's urine is dirty, say that it is positive for X. Instead of saying medication is a replacement addiction or crutch, say medication is treatment. Remove abuse from the titles of government agencies charged with creating treatment programs. Addiction is a brain disease. Medication is treatment. It is time for each of us to change our language and reflect the truth. Please visit www.bhli.org for more information.
Okay, that was pretty powerful, right? Just in a short few minutes. Our next set of spotlight topics will really focus on maternal opioid use disorder. And so we're going to have a series of presentations that will come forward to you. I will interject in between just to do sort of a quick introduction of each presenter as they come forward. So we actually have the pleasure of having Dr. Metwally here again. She kind of gave you some of her background already, so I will just highlight that she is an MD and a PhD, and is associate professor and the medical director of the Neonatal Intensive Care Unit here at the University of Maryland Children's Hospital, Department of Pediatrics, and University of Maryland School of Medicine. Her current research is focused on non-pharmacological interventions for babies withdrawing from exposure to opioids in utero, neonatal abstinence syndrome, and the impact of those interventions on their neurodevelopment in infancy. So please welcome again Dr. Metwally.
Thank you. Hello, everyone. Actually, I did enjoy all the discussions, all the questions, and as I said before, it's really eye-opener to see how you guys deal with what we don't see in the NICU. So I will be shifting gears, talk about the result. Babies who have been exposed to opioids in utero. Not sure if, no? Okay. So what is neonatal opioid withdrawal syndrome? It's a group of problems that occur in the newborn because they have been exposed to addictive opioids. And the word addictive here has a meaning and has a significance because it's not like a one-time exposure. It has to be a consistent exposure, especially in the last trimester. It could be the use of illicit or prescribed medications. It doesn't really matter. It matters in the context of management of the mothers. But for us, on our end, it depends on the dose. It depends on other factors I'm going to talk about. It's opioid at the end of the day. Heroin is not that much of a different as an exposure from methadone. It involves mainly the central nervous system, gastrointestinal tract. I'm not sure if you have seen a withdrawing baby before. The shivering, the tremors, the stiffness, the vomiting, diarrhea, it could really become, it's very difficult, it could be heartbreaking to see all of this. So this is not new. So in 2012, the NIDA did announce the dramatic increase in babies born with opioid exposures. So the increase is almost 5 to 6 folds nationwide. And if we come to our, what we see here in Maryland, it's pretty much the same. It follows the same numbers. There was an impressive impressive graph here that shows how the length of stay has increased, how the cost has increased, dramatic increase from the year 2000 to 2012. What about after 2012? Okay, so I would like to go back to the term. So why are some people using neonatal abstinence syndrome? And I'm using, or some others say, neonatal opioid withdrawal syndrome. There's no right and wrong about this, but we want it to be very distinct and very careful that it is opioid exposure. Just as the conference today and the workshop is about MOUNT, it is also about opioids because neonates could be withdrawing from benzos. They could be withdrawing from SSRI, which has the name of neonatal adaptation syndrome. So, but in particular, I'll be talking, and all my data I'm presenting is for babies with exposure to opioids in utero. What's the difference between withdrawal drugs and toxidromes? So the withdrawal drugs, it gets worse as the drug is leaving the body. So this is the maximum time of support you want to give the baby. However, in toxidromes, it gets better as the drug is leaving the body. And a classic example is the marijuana or the THC. We do screen in the NICU. We have all our babies, according to UMMC policy, are screened for, they have a big toxicological screen. They are screened in full-term nursery. They screen when they come to the NICU. We screen for opiates. We screen for benzos, PCPs, benzo, and other medications. We also introduced 2 new screens that were not there before the year 2018. And this is buprenorphine. We only had methadone, and now we have fentanyl to screen for. We use the urine. Some other places use meconium for exposures as early as the 2nd trimester, and hair for exposure as early as the 3rd trimester. But really, we focus on urine, which reflects the exposure in the last day or so. Sorry. So, let me first, the first part of my presentation, I'm going over the last 10-year experience of UMMC with babies with a neonatal opioid exposure. If you look at this graph here, it shows all kinds of substance use that the babies has been exposed to. And definitely the blue line is any kind of opioid, whether they are prescription, whether they are medication and rehab, or they are actually street opioids. And because this is our target group, this will be the highest used in the NICU for now's babies. However, of course, marijuana would be #1 for use and exposure, whether for our preemies or for our full-term babies. This here is for babies more than 34 weeks. A term baby is a baby who is 37 weeks. However, we included 34 weeks here because those are babies that we could monitor for withdrawal signs and symptoms. And it's very interesting to say that the smaller the babies are, the immature their nervous system is, and they do not show signs of withdrawal. We don't know what does this mean. Are they withdrawing and we don't know? Or are they not withdrawing? So at least we are just looking at the 34 weeks here. The second, as you could see, is the use of marijuana, and followed by tobacco use. So these are the combination, and actually, this is the polysubstance abuse for a population who is exposed to opioids, as was mentioned earlier. So what is the importance? The importance is an adjunct effect. So being exposed to one opioid is one thing, and being exposed to another substance that augments the action of opioid is another thing. So what does it do? So if you look at the receptors here, very briefly, the morphine receptors are very close to the CBI, which is the cannabinoid. CB1 is in the brain and CB2 is in other organs of the body. And you could see that the presence of the CBI, it actually augments the addiction process, and that means the habituation and the need for more and more. So being only on opioids is a big problem, but having a marijuana together with an opioid or having a second opioid, like being in a program and getting another opioid, this is all cumulative effect for severity of withdrawal. And you could see here nicely that if our threshold of the threshold of treatment. So if you have opioid and other substance exposures, you have a higher threshold to start treatment earlier. Looking at our 10 years data, these are just opioids, with all kind of opioids and included SSRIs, although they are not classic, but they do cause withdrawal, and they do cause neonatal adaptation syndrome. But what I wanted to point out is oxycodone and other prescription medications that initially you didn't see much, you are starting to see now. And if you look also at heroin use, which was minimal, you see more and more use of heroin by mothers. And this is baby stock screens and mother admitting to the use of those substances, as well as the mother's stock screen. So what's happening in the NICU? As I mentioned before, after maybe 24 hours in the normal newborn nursery, those babies starts withdrawing. And we're always keeping a high alert to know which baby will come to the NICU. Not every baby comes to the NICU. But this subset that I'm showing have all been in the NICU for the last 10 years. And the graph speaks to itself. There is a trend that is almost 6 times increase in the fold of babies admitted to be treated by pharmacotherapy. And a 10-fold increase for those who are requiring pharmacotherapy. But to lay the ground for the coming slides, you could see here that not all NAS babies require pharmacotherapy. So who are those? This is to show the burden of NAS here in the University of Maryland. And just to make this figure close to your minds, we started at the very low rate, almost 17 cases in 1,000 admission to the NICU. That was in 2007, 2008. We are up to almost 100 admissions, 100 cases per 1,000 admissions to the NICU. So how does this compare with national figures? In 2015, New England Journal of Medicine published a very important, and honestly it was very important for me, article on NAS in 299 NICUs around the state. And the admissions, or the NAS cases per 1,000 admissions, went up from 7 to 27. So I looked at our data. We went up from 17 to almost 100. So this is impressive data. In Baltimore here, we're witnessing 3-folds what the national average is witnessing. How long do they stay? They're staying longer. The last bar is the 2017 data, and you could see that they are staying longer and longer, and they are needing more medications. It's more complex medication exposures, and I'll also be talking about this soon. So what does it mean to the NICU? It means that in 2008, 0.5% of our annual admissions were NAS. And in 2017, 4% of our admissions are NAS babies who are withdrawing. What does it mean when it comes to total NICU days and bed occupancy? It means we were at 0.5%, and now we are at 7% in 2018. So they are saying not only that the number of babies admitted to the NICU are growing, but the length of stay is growing, and so they are occupying beds when a preemie who is a 23 or 24-weeker needs this bed. So, okay, we have the data from 10 years ago. Where do we stand? How do we learn? How do we put this data into perspective for future practice? So we just published this in June of this year. And I have to say, this is the first time in literature that anybody talks about race disparity in relation to NAS. It's not reported. It's not there. People tackled gender, tackled other things, but race has never been an issue. It's always okay, so that it is the disprivileged population, which in Baltimore is mostly African American, so they have the addiction problem. And guess what? No, that's not how we found it's working. So looking at the gray pies here, you could see among the black population, almost 70% required pharmacotherapy. Among the white population, 84% required pharmacotherapy. Okay, is this a coincidence? So the first time I presented this data in Grand Rounds in Peds, I was like, no, this is retrospective data. It has to do with mom's insurance. Maybe the blacks are not being seen because mom doesn't have the insurance. They are not getting the health. Did you look into that? So yeah, we're going to look into all of this, and I thought it was excellent point. So we look back again. What about the use of one medication versus two medications? It's a flip-flop. If the baby is black, then almost 2/3 of them, they only need one medication. But if this baby is a Caucasian or white, it is 2/3 of them need a second medication. No, it's not a coincidence. There is something in this population where race plays a great role, or looks like it plays a big role. We don't know, it's retrospective data. Let's move forward. So what we did here, we did what we call matching cases by using a propensity score. And in matching, among our population, we match everything. Okay. We match every single variable to make sure that the only difference would be either black or white. So we are matching gestational age, we are matching the gender, we are matching the exposure to methadone versus no methadone, benzos versus no benzos, and so on. So we did this for all, and we were able to get almost 96 blacks, 96 white, matched for every single variable, including even breastfeeding. And we found that even if you match for those covariates, the race stands out as really protective. The black race is protective from withdrawal. They don't withdraw as much, they do not need pharmacotherapy as much, and even if they need it, they don't go to the second pharmacotherapy. And again, I looked everywhere in the literature, it's not there. Is it just our population? We don't know, but we thought, let's just publish. And yes, it didn't take more than a couple of weeks to get accepted, to be published in Journal of Perinatology, to say, for the first time, the black race is protective. And if you see here, sorry for that, not used to this. So the less than one is protective. So if the baby is of a black race, it's more protective for the use of pharmacotherapy after exposure. However, if the mom was on the baby exposed to methadone or benzos, or even have a higher gestational age, not a lower gestational age, those babies tend to need therapy. And definitely, if you get started on therapy in the NICU, it has to be withdrawn weaned off very slowly, so it means increased length of stay. We looked further into the data to find predictive models, and this is just to walk you here through the different predictive models. The red ones are the modified Finnegan scores. The blue is the doses of medications, of morphine and others. This is our protocol, and we try to put all of this with the help of our colleagues and collaborators from the School of Pharmacy. And we were able to come with a predictive model that definitely had race in it, exposure to methadone and other risk factors, to predict which babies will come to the NICU and which babies will need pharmacotherapy. Very nice prediction. Here, these are the prediction models that almost overlapped and were predictive for the whole length of stay. This is our modified Finnegan score. It is modified because it's only 19 items. It does have CNS, it has metabolic and gastrointestinal components. What about predicting the modified Finnegan scores? So we could predict pharmacotherapy. Could we predict modified Finnegans? Yes. Yes, and again, our collaborators at the School of Pharmacy were able to come with very accurate models that actually we submitted a patent for this predictive model. Future directions, and a very important piece to put into all of this. Breastfeeding. Well, the American Academy of Pediatrics said we could not really allow mom to breastfeed if she's getting more than 20 grams per 24 hours of methadone. They changed their statement, and they said they just need to be in a program and to be abstinent in the 90 days prior to delivery. What did we find? To cut, because I'm running late, look at this graph. These are the breastfed infants, okay? These are the formula-fed infants. It's a small number. This is the preliminary results of our study. And you could see it's how impressive. If the babies were breastfed, they don't need as much morphine if the babies were formula fed, where their morphine use goes up higher. There seemed to be a relation with breastfeeding that makes them discharge early compared to their peers who are on formula feeds. Again, looking at the graph in yellow, you could see that this just shows that the calorie and the weight gain is inversely proportional to the morphine, so you have a better weight gain as the morphine dose goes down. So definitely, we want to look into something more or different than pharmacokinetics. We have other, again, just to tell you, there is a volunteer cuddlers program that we welcome the volunteers to come and hold the babies and to provide non-pharmacological care. My last piece, genetics. I'm not a bench researcher. I don't do basic science, I do clinical science. But that to me was fascinating because maybe it has to do more than what we are talking. It's genetics. How could I blame someone who is too short, too tall, if it is already genetically determined? So what we are believing now, that 50% of the problem is genetics. And we cannot take this piece out. And people need to understand the importance of these implications. Because it's all, as you see here, the GABA is the gatekeeper. It suppresses the dopamine release. The dopamine is what gives the sense of pleasure. So if you get morphine, it gets into those receptors and suppresses the GABA, release the dopamine, and gives the rewarding sense of, I'm happy, I'm good. If these receptors have some polymorphism in some people, makes them vulnerable, then these are one of the receptors we are looking at, and those are the brain opioid receptors, or the PRM. The other one is how fast is dopamine degraded and taken away, and these are the COMT. To make it brief, this is our second part that we are looking at now. We are looking at genetics. This is the whole SNP arrays we are looking at. We already were able to collect dyad SNP arrays on moms and babies. And we have some preliminary data, million things. We put over 99 different prenatal, natal, postnatal, feeding, height, length, everything into the model. Ran very intensive deep learning models. These with our collaborators from the Institute of Genomic Science, together with our collaborators from School of Pharmacy. And what did we find as a preliminary results? Look there. White race. Amazing. We just reported white race for the first time to be associated with a higher risk. And black race has a lower risk. It's a negative. And then came the PNOC with this genotype. This is a genotype that's only in Caucasians. Are we putting the pieces together? It's again the white race. There is something that makes the black babies resistant to withdrawal, needs of drug, they have lower length of stay. And then came other things in the model, very interesting, like the length of the baby and not the weight of the baby. So in our model, we propose here that the black babies are less have lower Finnegan scores, so not only length of stay, their Finnegan scores are lower compared to the white. And if a baby is carrying the SNP array or, the SNP polymorphism, then they actually tend to be having higher scores compared to others. Still to go, if you look at this prediction model, the line in the middle shows the aggregation around the line, and you could see that most of this aggregation is for the white. What about the black population? They are all scattered. We cannot yet reach a model that could predict the need of pharmacotherapy among black babies. My last slide here to say, it's a long way to go. There's a lot of take-home messages that I'm sure Becky is going to be talking about. We need to predict which babies need pharmacotherapy, so we need to keep them in the hospital for a longer length of stay. To predict admission from normal newborn nursery, to predict the length of stay in the NICU, the need for early intervention, the need of pharmacotherapy, outcome. It's a whole vicious cycle. And I would like to end my presentation by the adverse childhood experience. So this is a score that's given to children at home that experience 2 out of 4 disadvantages. One of them, if they were exposed to abuse of violence. The second, if they actually witnessed abuse or violence. The loss of one parent, and having a parent in the household that is exposed to, that has addiction problem, whether it is alcohol or drugs. And looking at the national numbers and the numbers in Maryland, very impressive. 30% in Baltimore has an ACE, 30% or 31% are disadvantaged. They have poor parenting reference. They have a lot of other conditions versus nationwide, we are talking about 27%. So definitely we have a problem here in Baltimore, and it extends. It extends to discharge, to toddlers, it extends to school age. And my 5 cents, because it is genetics, it should be prevented. It's very difficult and challenging, and it's difficult for those moms to revert. What you really need to do in middle schools and high schools, and it's not awesome, it's not hip, it's not cool to try drugs because you could just be looped into it because of how your genetic profile has been put together. Thank you.
Thank you, Dr. Metwally. Our next speaker will be Kathleen Hoke. She is a law professor, the director of the Legal Resource Center for Public Policy, and the director of the Network for Public Health Law Eastern Region at the University of Maryland Carey School of Law. Through this center and network, Kathleen provides technical and legal assistance to the state and local health officials, legislators, researchers, and organizations working with law and policy change to improve public health. She served with distinction as the Assistant Attorney General, as a Special Assistant to the Attorney General of Maryland, prior to joining the School of Law in 2002. Let's please welcome Kathleen Hoke.
PowerPoint? Yes. Hi, everybody. It's me again. I think this is the last time you have to hear from me today. You can always enroll in my class at the law school if you're interested. While they're finding my presentation, so thank you for the kind introduction, Michelle. I first want to dispense with something that just an issue here. Everyone calls me doctor in the hallway here, and I love it, and it's amazing. There are 2 Dr. Hokes in my family. One is my brother, and the other is his wife, and they matriculated here at the School of Medicine, but I am not a doctor, and a JD does not qualify for me for that title, so Kathy is perfectly fine. But I'm so thankful for all of you who came to listen to us on this interdisciplinary. I think I'm one of like 2 or 3 of my colleagues at the law school who respond to any interdisciplinary work, so you'll see me if you're in the IPE realm quite a bit. But that said, a lot of what y'all were talking about was going way over my head because I didn't know some of the terminology. I hope that I don't do that to you in talking about the law, but to be sure, you probably know as much, if not more, about some of this than I do while you're in practice. So. There we go. HIPAA, I have to mention, because we're going to talk about sharing medical information or sharing information because of medical information that we have about patients. And the first thing that any decent medical professional says is, wait a minute, what about HIPAA? Because unfortunately, that law has terrified people into thinking constantly, oh, wait a minute, what about HIPAA? It's probably not as scary as it seems, but lawyers who work for hospitals are super risk averse, and so they make it seem a little bit scarier. But to be sure, HIPAA here doesn't interfere with the ability of a healthcare provider to share information if to report child abuse or neglect to the appropriate entity. That the title of that department varies, across the states, and so they use that language. Or to avert a serious threat to the health or safety if reported to the appropriate entity. And so these have been construed. Both of these exceptions have been construed pretty broadly to cover most of the issues that we're going to talk about today. Equally important is CAPTA, which I'll talk about, which kind of swallows the need to even discuss the exceptions in HIPAA. There is one caveat of what information can be shared, the mother's medical information versus the child's medical information. And it is clear that HIPAA allows the sharing of the child's medical information for these purposes. And there is a bit of dispute or complexity to the question of how much of the mother's medical information can and should be provided in this case. But again, we'll talk about the impact of CAPTA on that. So I'm going to talk about a couple of different types of laws. First are there state laws that actually criminalize substance use during pregnancy? And the answer is by statute now, no. So historically, there have not been states that are criminalizing, explicitly in statute. In Tennessee, they became frustrated because the court there, the highest court there, ruled that they could not charge a mom with, substance use as, a crime during her pregnancy. So the legislature passed a statute in 2014 to do so. It did have a natural sunset clause in it of 2016, and I think the outcome was no one was ever prosecuted under it. All medical professionals said this is a horrible, bad idea. Law enforcement said this is a horrible, bad idea, and so they did not renew the provision in 2016. So that's kind of the good news, right? But some states do allow for criminal charges to be brought against a mother for her substance use during pregnancy. Typically, these charges come, however, after the child is born. So rarely is it occurring during the pregnancy, but it is that pregnancy-related conduct that might result in these charges, sometimes because the fetus does not survive, and so the mom gets charged under any of these. In Maryland, we don't tend to see these types of charges, and so there's not a definitive court ruling on whether they could be brought here in Maryland. So what does the impact of the involvement in the criminal justice system have on a mom's access to, or pregnant woman's access to medicated assisted treatment? So evidence suggests, and I mean, you've heard much of this throughout the course of the day here, but pregnant women who are referred to treatment through the criminal justice system are the least likely to receive MAT, right? So if the policy basis for the criminal charge is to get help for the mom and the baby, it's not working because they're not being referred to what is probably best practices from a healthcare perspective. Moreover, there is a health inequity here. I could probably say there's a health inequity here in everything that we talk about in this room, but the disproportionate impact on vulnerable populations, on people of color in the criminal justice system lets us know that that is also not the right route if we're really seeking to help women who are using substances during their pregnancy. I will say, I just wrote a little note here. One of my colleagues who I follow on Twitter, if you're interested in law and policy around substance use, you might follow him. His name's Corey Davis, C-O-R-E-Y Davis. But he tweeted today, nearly all illicit drug laws are implemented in a racially discriminatory way. He said more, but I was like, yep, that's exactly what I'm getting at here. So we don't think using the criminal justice system is efficacious. So what about the civil justice system, right? So there's criminal and civil. How's that work? Well, as you can see here, 23 states and the district have a specific statute or regulation that allows for the finding of child abuse while the woman is pregnant. So we're not talking about after, we're talking about during the pregnancy for that substance use during pregnancy. 3 states consider it grounds for civil commitment. Civil commitment is just like incarceration on some level, but of course it's not through the criminal justice system. And Maryland, I think, fortunately, does not have either. questions going to come, oh, would that include prescription, if taken according to the prescription prescribed for that mom, while the definition does include the medications used in MAT, there is an exception in all of these statutes for if the mother is using the medication as prescribed by her physician. So there is recognition of that. Again, Maryland, not up there. State laws on reporting, and this is talking about reporting while mom is pregnant. I'm not talking about the CAPTA stuff. We're going to talk about that, but we're talking about during the pregnancy. 25 states and the district require healthcare professionals to report suspected prenatal drug use during the pregnancy. Aren't you glad you live here? Don't you wish everyone did? So 8 states require healthcare professionals to test pregnant women. We heard best practices are to do screenings at various times during the pregnancy for all populations, mostly because we make assumptions about who may or may not be using illicit substances during pregnancy. But to mandate the screening or the testing, 8 states require that. And it won't surprise you that those 8 states are included in the 25 states that then allow for a reporting of suspected prenatal drug use as child abuse. So again, fortunately, Maryland does not have either of these provisions. So just to ponder. You've talked a lot about this today, and so I don't, feel, I don't want to repeat what has already been said, but just to maybe put it up there, and then have you be thinking about it during the course of your day. But policymakers suggest the reason behind the laws that they're passing, and I say suggest because they're never quite clear for why they're passing a law, is that they want to deter maternal substance use. Provide the opportunity for the criminal justice or the social services system to intervene in that critical time while the baby is still, baking, right, in utero. And so that's the stated basis. But there is no evidence to support that the criminalization of substance use during pregnancy reduces child morbidity or mortality or maternal morbidity or mortality. And it certainly doesn't save the state any money if that's what the legislators really care about. So it really doesn't work. What does it do? Well, this is what you've talked about. It interrupts the patient-provider relationship. It deters mom not only sometimes for seeking prenatal care or postnatal care, it might prevent mom from seeking any health care whatsoever during that period of time for fear of being reported. So she's not maybe getting her flu vaccine. Maybe she's not coming in for a respiratory infection that now is become pneumonia or et cetera. Any care she's not coming in for. Postnatal, maybe she's not bringing her baby in for routine care or for small or even maybe acute issues because she is afraid. And we talked about that earlier. Now, CAPTA, and then a little bit about the Maryland law for CAPTA. So for those of you who don't know, that's what it stands for, because I know when people throw around acronyms, I'm often left behind. But it's really a federal law that does what so many federal laws do. It tells states, I have this money for you, and you can use it for all these good purposes, but you gotta do X, or you're not allowed to do Y. And that's exactly what CAPTA does. It says, in order for you to get these funds, states, you have to have mandatory reporting by healthcare providers to the appropriate social services entity of a child who has been affected by prenatal exposure to illicit substances. So we, of course, have that. Importantly, CAPTA does not, nor does Maryland law, nor do most states, require or even suggest reporting to law enforcement. We're talking about reporting to, what was your name? Sarah, who works for Baltimore County where I live, and thank you for the work that you do there. She's not going, her goal is not to get mom in jail or to take baby away from mom. Her goal is family together. So just a couple of definitions from the Maryland Code. You can see here what is a CDS. Again, it does include the drugs that we use in medicated assisted, is it therapy or treatment? Treatment, thank you. Again, I'm not a medical professional. What is a substance-exposed newborn? Here's the definition for you. Newborn is defined as within the 30 days. If the baby was born out of state but is here being treated within that 30-day window, they are covered by CAPTA, and so reporting would have to actually occur. There were some changes in 2018 that have been referenced here, actually in the statute as well, because we were out of compliance with federal requirements. But I won't go into those details. So a healthcare provider involved in the delivery or care of a substance-exposed newborn, who is that, right? I mean, or who has to report? That's who has to report. What do you have to report? First, virtually immediately, an oral report. Second, within 48 hours, the written report. The details for what needs to be included in the report is in the statute, and so I won't provide those details here. But what are the exceptions? First, if you know that your institution or someone else in your institution has already done the reporting, which is probably the case for many of you, you report to someone else who actually does the reporting, you're fine. And then there are the other exceptions that seem to be swallowed up by the whole, but the mother was using CDS as prescribed. Again, the MAT, newborn does not display effects of withdrawal or FAS, or the newborn is not affected by substance abuse, all determined by the healthcare provider. Remember that reporting to the social services agency does not mean that the baby will be taken away from mom. It does not mean mom will be charged with anything civilly or criminally. What does it mean? It means that maybe nothing will happen if there's no need for intervention. But it may mean that other services are provided to mom and her family that will help her transition her child back into her home, or to keep her child in her home with her other children. And so, there can and should be good outcomes if CAPTA is working appropriately. And I do believe a lot of folks behind CAPTA intended this, and a lot of folks working in the field hope to make that happen. Again, I have 1 minute left, so I'm just going to throw the slide up for you to be thinking about the things that I said before about the ethics. Well, are they different than in the criminal context? Maybe it's kind of the same purpose as getting in at that critical time to get services, to get intervention done. But maybe, sometimes this works out well. So I don't think, some people don't like CAPTA because they don't think there should be any engagement mandated by healthcare providers. But at the end of the day, there may be some value in it, particularly when we have good plans. There's some research on the collaborative approach to plans of safe care, using an interdisciplinary approach there that demonstrate that the end result for CAPTA can be very beneficial to both mom, baby, and community, and I think the healthcare community as well. So, thank you.
Thank you, Kathleen. Just really quick, we're going to take just a second to take any questions that you may have for Dr. Metwally or for Kathleen before we move on to the next two presentations. Does anybody have any questions? So we got a couple of hands. Let's go here first in the dress.
Hi, thank you for your presentation. I know that this is an opioid use summit, but do you know if there's any push to change CAPTA for marijuana that is legally prescribed, but we have to report everyone even if it's legally prescribed because it's federally illicit?
So right now it has to be reported because it is federally listed, and there have been, over the course of the last probably 5 years, lots of bills introduced, or at least conceptually introduced, to change the scheduling, but one that would specifically, the problem is everyone thinks you have to change the whole problem, which is descheduling marijuana, which is a huge task, and you have to have something to do with it once you deschedule it, versus capturing this particular problem. But the federal government is loath to say, they're not enforcing, federal laws against medical cannabis or even recreational cannabis in those states, but they're loath to pass a law that fixes this CAPTA problem. So people are talking about it, but I have not seen anything even proposed as a legislative fix.
Okay, question in the back. You're done?
I just want to wait.
Yep.
Okay.
Oh,
Then can I ask my question first? Hello?
yeah.
So I am the one and only outpatient OB social worker for the University of Maryland, and I've been here 11 years. This reporting is crap, and I'm very sorry to say this. I have to sit and try to explain to patients what may or may not happen, and it is different by jurisdiction. And most of our patients live in Baltimore City, and they are not getting this nice approach of, we're here to help you. That's not what's happening. And so I think that I have to tell my patients to be as honest as they possibly can, and that we try to well document everything that goes on, but it literally is a lottery based on which worker gets you, how the system takes care of you. So I think that more and more places, like I know Hartford County has a very specific program, the county now has it, but we got a long way to go. It is not something for people who have been their interaction with a system that has failed them. Why would I believe that you're here to help me when you really haven't till I've gotten to this point in my life?
Yep.
Okay.
Okay, sorry. Michelle, can I go? Sorry, this is cute, but it's the weirdest thing to talk into. I'm going to try my best. My question's for Dr. El Metwally. I was wondering in the first few slides where you presented the data from the article in the Journal of Perinatology, as a health services researcher who works in health disparities, and whenever you see differences in treatment among Black and white patients, my first instinct was, well, is there undertreatment of NAS symptoms among Black babies, right? Not necessarily that, oh, they're less in need of treatment for NAS. So I'm wondering if you could a little bit clarify how you got to think through that data in a way that said what you eventually said, which is that Black babies may not need as much pharmacointervention when it comes to NAS symptoms, rather than seeing it as an undertreatment of symptomatology that could be due to bias and racism in the treatment of Black babies.
Excellent question, and actually, thank you for this, because once admitted, we go by protocol that I showed earlier. I kind of skimmed through. It depends on scoring. It depends on how bad the baby is scoring on the modified Finnegan scores, how much need, then we just give medications. And this is retrospective data. So it's not that we are controlling any kind of recruitment into one arm of the study. This is just looking backward 10 years and seeing who needed what. And honestly, when we started, nobody reported race before. Why it is, I totally understand your point, but it is just not one of the things that we expected to see. And has to be taken with a grain of salt because it's retrospective data, but we did our best from a design to parse out the effect of pharmacotherapy regardless of everything else. So in an intensive care unit, there is nothing, I have to say, everyone gets equally everything. We don't look at this. Insurance is paying for everything. Care in the NICU is bundled. That means I'm not going to bill for something more on this baby versus that baby because, yes, we are bundled. So there is no whatsoever motive for any kind of, let me get an extra X-ray on this baby or give this baby less because I'm doing, no, this is not even existent. So it is definitely, I could tell you, this is totally blinded, has nothing to do. It is just a finding that the genetics profiles are now supporting. There is something in genetics that makes one race more vulnerable to the other. Yes, please.
I'm just going to say, I'm really glad that you asked that. And I think that you brought up a good point. And not to like challenge you on what you're saying, but it is so prevalent, these issues that she spoke of, especially in Maryland. How could you possibly say without a shadow of a doubt that these things do not happen in your entire unit when the history says quite different? And so I'm not going to lie, when you first said that, I kind of was taken back because this is something that we hear often, is that, oh, well, there's less need. And it kind of makes me feel like when we think about in terms of mental health, like Blacks aren't vulnerable to mental health disorders and things like that as well. So I'm just kind of challenging you on what you're saying regarding that, oh, this doesn't happen in our unit. And to me, I'm just saying, I'm just saying. I'm not liking what I'm hearing right
You know,
now.
I honestly could see where you're coming from. And I know, but let's just look at it from a scientific perspective and only science. As I said in one of my graphs, we need predictors for different race, and predictors for white are different from black. If this is not addressed on scientific basis, we'll never be able to help babies. I have to know, it's an advantage, correct? There is some kind of natural advantage for the black race, regardless of exposure, that they are not needing as much help, but they are not being readmitted. They are not, we didn't get any, we looked back to see if they got readmitted, if something was skipped, and the readmission is not just for this race, it's just admission for babies, readmission for babies in general. We didn't find. And then that's why we went to genetics. And I see your point, and it's a very valid point, because I don't want this to be used like, oh, this is a license. This is a license that if this is a black race, then they could actually be on higher drugs because their babies will do better. But you know what? They stay less, they need less drugs, and they are the ones who do not come to us from full-term nursery. They are discharged earlier. There is something, there is a missing part in this quiz. And to me, it's genetics. As I said, when I reported this data before, the question was, are they not showing up because they do not get health insurance? So you have less black race getting the health insurance, and they are this privileged population. Well, the NICU doesn't know that. I know who's admitted. So, and an infant that is exposed, it doesn't matter if this infant had insurance or not. He's still withdrawing, is has symptoms and needs treatment. So it is very interesting, and I think, and I open it to the floor, what else that we could parse out to make sure that we have an answer to this question?
I just, for someone who's a non-MD in the room, I just have some questions about the Finnegan score and how that is scored, and if there is some potential subjective elements to that.
Mm-hmm. Absolutely. Absolutely. So yes, Finnegan score is a subjective score because a nurse who is trained and seasoned would score some kind different than a nurse who's not. I don't have those slides, but there was this very nice studies that came from Maine, from Dartmouth Hitchcock, and showed how the nurses score prior to an educational training session or program, and how they score after. And it's very subtle. Like I've seen, when I get a high score in rounds, I tell the nurse, what is the baby scored for? And she would go and say, oh, for MSs. All right? So he got a 3 for MSs, the high score. Why are you scoring for reflux? If you score for the 3, you cannot go back and score for reflux. I could not have a 1 and a 3 because it's one item. 3, the baby got the maximum score. This is just an example. So one of the things that we've done, and this thankfully this was through Maryland patient safety program, we did and the VAUGHN studies and the modules. Who are aware of the VAUGHN modules? Okay, so all the NICU, we had training in the VAUGHN modules, and they were excellent ones because we got to know a lot of what we talked about, and then we got to know that we need to do training in our NICU, so we purchased the videos, and we actually trained the nurses how to do a good modified Finnegan score. That being said, there are caveats to that. My retrospective study is a 10-year-old study, so there was no training at that time. I would say the older nurses, the seasoned nurses, were more qualified when it comes to scoring compared to the new nurses who are just graduates of nursing school, and they are getting the training. The other thing, we moved from an open bay NICU to a single family room NICU in 2015, September 2015. How did this affect? And I want to tell you, because this one of the reviewers asked these questions. We went back to the data, and we decided we're going to publish this alone because guess what? Guess what? Guess what? Since we started this new NICU, everyone is getting the treatment. It has to do with the scoring. They are not waiting. They are, a nurse is responsible for 2 babies. She cannot attend to 1 baby. There isn't this open bay with 8 babies in it with 5 to 6 nurses supporting each other. There is a lot of things to do with new nursing graduates that, okay, let's just give the medicine. So it is the easiest thing. Who wants to hear a baby crying all the time? It breaks your heart, shivering, shaking. So we have more tendency since we moved to the new NICU, which is the private room one, which should be an advantage for mothers to be there. And it's not happening. And guess what? I looked back into our data. How many of the mothers are rooming in with their babies? Less than 40%. How many mothers are even walking into the room, not rooming in? Less than 20%. There is a long, long way to go.
Okay, we're going to stop there only because we're going over on time. So we want to thank again, Dr. Metwally has to get back to the unit.
Thank you.
So we want to thank her again and thank Kathleen for her presentation.